In honor of Lucy Wiley, who sent us, she's not here, but she sent us a thing. Most interventions are aimed at destroying tumors. Why are we not getting upstream with this disease and working to prevent or at least minimize the development of tumors? By the time we have tumors, it's too late in the game to get the upper hand. Think Lucy's first premise is wrong, that if you have 40% of people who are alive 20 years later, we are getting upstream. We are preventing things. We've changed the whole paradigm of how things are working. What is being done in the areas of prevention? There are a whole bunch of stuff that's being done in chemo prevention, with treatments, with a variety of natural food products. There are dietary interventions that are being done. The trouble is that, like I said, we send in 3 R01s in a year, and the chance of those things getting funded, zero, slim, zilch, and they've all left town. Because, and if you think about it, there's some logic. If 1 out of 8 women get breast cancer and 1 out of 80,000 women get carcinoid, if you were the government and you had to say, where am I going to spend my money, you would rightfully say, I'm going to spend it where it affects 1 in 8 women. I think that what that does is charges us as a group to raise money to do our own research. Look what Coleman's done. If every ice cream cone at Baskin Robbins gave a penny to carcinoid research, you know how much money there would be in a year? If McDonald's
you might get fat again, Gene, though. Be careful.
Who?
I said you might gain weight again.
No, I have resolve. I am going to be skinny. All right. Let's see, Dr. Liu, Gallium-68. Why shouldn't everybody have a Gallium-68? I got $5,000 in my pocket, and I want to spend it. Why shouldn't I do that?
Well, that's not actually an unreasonable. So on a more practical aspect of it, the problem is that gallium is not FDA approved. Okay, so you can't just get it. It has to be done under trial, and we've shared our paperwork and stuff with a lot of the centers around the country, including in New Orleans. And so we're trying our best to get this going. It is not so simple. So for us right now, there are no deep pockets, right? So a lot of it's just kind of covered by donations by patients and things, and I am extremely grateful. And it just kind of keeps the program going. But it's not cheap. It's not cheap. So
and what would, and this is not a criticism, he's a leader, a thought leader in what's going on. But when it's all said and done, what's the FDA going to do with a physician-initiated IND data?
Well, it's limited. He's right. So what he means is here's one guy with his one experience. What does that really mean?
And it's not just one guy. I mean, Odo's doing it. Ed Rollins doing it. Mm-hmm. The Indianapolis people are doing it. The UCLA people are doing it. There are a lot of people doing Gallium-68 scans. But when it's all said and done, all that data is going to get put in a giant circular trash can and thrown away because it wasn't a corporate IND.
Well, I'm not so sure that's exactly true. So
I'm a pessimist.
Yes. So I think there's a little more to it. So we do work pretty closely because I do believe very strongly in it. So it's like having fire or a screwdriver. I mean, yeah. It's a tool. It's a very effective tool. I showed it to you. And so really what it is we're working with the societies, we're actually working closely with the FDA to work on trying to get this approved so that it can just be given more widely. It's a complicated logistic process. So now if you do have $5,000 and you want to get the scan, you can, right? Just as Dr. Altering said, there are centers around the country that are starting to do it. It's just that it has to, you just have to cover it because sometimes
you're part of a study.
Correct.
It is not an FDA-approved product.
Right, exactly. And so the studies are, for example, our study is to generate data on safety. So the ones who have had it here, I made you draw your blood, I made you do EKG, which so far no one has had any problems with. But it is required. So I have to jump through these hoops in order to get it approved someday. So those are the things that we're working on. So, hopefully we can have it. But if you need it and you want it, you call me, you call, Dr. Walter, you call Dr. Odoricio, and, we get you in the trial and you get your scan, you have that information. The quality of our scans is no different from the quality of the scans performed not here. The quality at Vanderbilt is significantly better. but the quality, but really the nature of our scans are no different than the nature of the scans performed around the world. So there's no need to keep running to Europe to do it.
Okay, have we ever seen a NITS change its identity? Dr. Thomas?
Yeah, actually, well, that doesn't happen too often, but there are some folks who have low-grade disease where once in a while I've had one patient who developed a high-grade neuroendocrine tumor, and it happened one time. It was sort of unexpected to see that. Dealing with a low-grade disease where there's a slow-growing tumor, living with it for years, and all of a sudden a really high-grade process occurs, but that doesn't happen too often.
Dr. Zollinger, the guy who found the first gastrin-producing tumor in the United States, had a patient that went from gastrinoma to insulinoma to somatostatinoma over 20, 25 years. So not only can you change from low grade, not very proliferative, to high grade, highly proliferative, but you can also, if you're a PNET, you can change what you make. I've seen one or two, and Eric and Phil hop in on this, patients who appeared to have no function, i.e. they didn't make serotonin, they didn't have the carcinoid syndrome, who over time, either because the tumor changed or the tumor grew and there was more tumor, developed symptoms of flushing, diarrhea, and the syndrome.
Who was the most famous person to have a pancreatic neuroendocrine tumor?
Dave Thomas, Steve.
No, pancreatic.
Pancreatic, Steve Jobs.
Steve Jobs, right. So how did he describe his tumor initially? He considered it a nutritional problem. Remember that? Developed 10 years ago, called a nutritional problem. So he had actually an insulinoma for which he chose, you can always
Glucagonoma.
No, he initially had an insulinoma. Initially it was an insulinoma, and it converted into glucagonoma. So it's that's a very famous example of a conversion.
Okay. What's the difference between sandostatin and the other shots? Can't remember name. The other shots are called Somatuline Depot, produced by Ipsen, approved in Europe for 30 years, right back when octreotide first got approved. And it is subcutaneous injection, short needle, fatter needle, and produces blood levels at maximum that are about twice that of LAR. So if you're at LAR 30 every 2 weeks, and you compare that to lanreotide or Somatuline Depot 120 every 2 weeks, your LAR will be about 5,000 picograms per ml blood level, and Somatuline Depot will be about 10,000.
Prepackaged too.
Prepackaged,
Yeah, no, it's a big
and you
deal.
don't have to mix it. You can carry it in your suitcase. You self-administer it. You don't got to go to the doctor. And the data, the study just got done, going to be presented at ASCO, and they hope to have it on the market in about a year or two.
And the short-acting too. Don't forget, there's a short-acting version of octreotide, which is just a little subcutaneous injection, which works about 4 to 6 hours.
What's the name?
Octreotide.
The sandostatin has two forms, a slow-release form called LAR and a rapid-release form called aqueous. The aqueous is the stuff we put in the pump. Okay? What exactly is a stable terminal ileal mass? How can you differentiate the following? Posterior liver mass grade 4, celiac axis lymph nodes grade 2, numerous mesenteric nodes and midline mesenteric mass, terminal ileum grade 3. I guess I don't understand how you what do you mean differentiate? You just did. What would you do with a terminal stable ileal mass in somebody who has a liver met? Phil.
Well, tumors in the GI tract from the mouth to the other end are not real smart. They only know how to do three things. They can obstruct, they can bleed, and they can perforate. Fast-growing tumors like colon cancer and things like that are more likely to outgrow their blood supply at some point in time. Part of it dies off, and it necroses and perforates, and so that's a more common finding, even though it's not real common with stuff like, say, colon cancer or stomach cancer, but that's what they do. More commonly, they bleed or they obstruct, and carcinoids are no different. That's what they do. If you wait long enough, they're all going to do one of those two things.
And remember, they keep shedding tumors into your lymph and into your blood.
They keep giving off daughters and just makes the tumor burden elsewhere worse the longer you wait. So it's like, I really have trouble with people saying, well, you just have a little small tumor and it's not that bad, let's just kind of watch it. It's like, well, we just have a little fire in the frying pan in the kitchen, we'll just watch it. So now the kitchen's on fire and spreads, and so, well, we'll just watch it, it's not that bad yet. And so it spreads, and now the house is on fire, let's call the fire department. Okay. And the house burns down, and they find that ashes.
Somebody get him in the head with the CO2 extinguisher, please. Okay, Eric, what do you do with a stable mass on the, somebody has a liver met that's biopsy-proven carcinoid, and there is on colonoscopy, or a gallium scan, or a trio scan, or a CAT scan, there you see the terminal ileal mass. Do you watch it, or do you take the little mama jama out?
I don't. I always take it out, and let me explain why. So the term, just as Dr. Boudreau said, they can cause problems, but in many people they don't cause problems. But it really is just a matter of time. So you have to understand that, you know, as we are all, the three of us here are general surgeons as well, in addition to being neuroendocrine surgeons. And so we have had our fair share of disasters, like blown apart bowels and, you know, leaking pancreas, you know, you name it. And so it is always easier for us to do an operation when you're strong and healthy than it is when you are dying because your bowels have exploded, okay? So we try to do these operations when you're strong and healthy, get you out in 3 days, and then just recover very, very well. And one of the problems is that the data would suggest that, in fact, there is perhaps some biology and perhaps some shedding because people don't do as well when you can't get their primaries out. But more importantly, when you get in there, especially with someone who's experienced as Dr. Weltering or Dr. Boudreau, is that they'll do a more complete operation for you. So even in the setting of metastatic disease, we will go in there and take out your primary. Now, while we're there, though, and if your liver tumors are amenable to it, we would love to debulk that as well, too, because many centers, including LSU and Moffitt and places like that, have demonstrated that you can do a very good debulking operation. Essentially, what you do is you set the clock backwards in time, right? So by resetting the clock,
You stole that from me.
yeah,
You stole that, that's my Cinderella.
that is not the only thing I've stolen from you.
That's all right. All right, well, we gotta keep moving. Dr. Thomas, this is for you. Who's your favorite patient? There you go. Okay, so this is a question for me and the whole group. How different is the New Orleans survival rate than that, for example, Mount Sinai in New York, Vanderbilt, MD Anderson, or Iowa? Where are their published rates? Why aren't they talking about their published rates?
I can answer that question. I have not been doing this as long as Dr. Weltering has. There's no question about that. So it's not worth it for me to do it. Really, the very challenging thing about calculating survival, and I think everyone would agree, especially with that SEER database that we go through, is that it's hard to tease these things out. For example, a lot of you will have seen Dr. Weltering, then see Dr. Me, and see Dr. Thomas, and then so, whose survival really is this? So all I can do is
Patients.
Yeah, indeed. You're right, indeed.
And so you put them all together and they form a herd.
That's right. And so, I cannot take credit because sometimes it's Dr. Weltering and Dr. Boudreau's good work, but, sometimes they come see me because they live in Tennessee, or something like that. We will do that as our experience continues to grow.
But you ask a very good question. I will tell you, if you compare our data to the data of Dr. Kjell Oberg in Uppsala, Sweden, who's coming to visit Eric and Eric trained with, our data on cytoreducted people who have stage 4 is almost identical. And you look at other published reports. All you gotta do, if you wanna know what's out there, go onto Google, type the word scholar, that will get you into Google Scholar, type survival rates for mid-gut carcinoids, or cytoreduction survival rates for mid-gut carcinoid, and you'll get 10 or 15 papers that'll show you survival rates in Europe, survival rates here, survival rates in places that have a very active cytoreduction program, and places that tend to treat more high-grade tumors. And remember, I'm not talking in my group about doing a lot of high-grade data or treating high-grade people who have the Ki-67s that are 50%. Those will go to people like Dr. Thomas, Dr. Yao at MD Anderson, Dr. Kolke in Boston, et cetera, where they have a whole different set of patients that they're treating that doesn't make them good or me bad or them bad. It's just that we have different areas of expertise. How often should you have an Artreus scan, Dr. Thomas, and who should have rescue shots?
Most times I order an Artreus scan at baseline, and in the follow-up patients, I think it's probably more important to check a CT scan probably every 6 months to a year. I really don't check an Artreus scan unless there's some measurable disease. Maybe some other institutions would do differently. But if your CAT scan doesn't show much disease, I'm not sure what more to go after at that point in time. I know some centers probably maybe do it once a year or so, especially if you don't have much measurable disease on a CAT scan or MRI.
Okay, Dr. Thomas, another one. Can a greater than 20% Ki-67 tumor from a biopsy of the primary act like a low-grade tumor?
Oh, that's so is it 67%, you said?
No, it's a 20% Ki-67, greater than 20% Ki-67. Biopsy was done on a primary. Can that primary, even though it has a high Ki-67, act like a lower proliferative rate, low-grade tumor?
You know, the most important, a lot of people look at the numbers and sort of regimented and follow the strict guideline that as though if you're high-grade disease, we ought to just treat you like a high-grade patient. And there are some patients who are like borderline 20, 22%, 25%, that may potentially behave a little bit better. Or if they had a low-grade process and they tend to behave even, like a high-grade disease, then they ought to be probably treated as a high-grade disease. It just depends on more important is the clinical behavior of how the disease is acting, not by the number. And so I think that's the most important point to me.
Oh, and rescue shots. Who should take rescue?
If you have symptomatic disease, so most folks who have functional neuroendocrine tumors not well controlled on the long-acting, you probably need to be taking short-acting doses every 2-3 times a day. Just because you're taking the long-acting drug doesn't mean that's it, you're done. You need to be on some short-acting control.
And Novartis didn't talk about this, but go back and read the original paper that got the drug approved. 30% of people used rescue every week, and 70% of people used it at some time on the study. So they don't talk about everybody should be thinking about using rescue and having it at home. A lot of people, I think, are symptomatic. They have flushing, they have diarrhea, they have wheezing, they have malaise, they have fatigue, they have bone pain, etc. And they were never offered rescue. So if you weren't offered rescue, be doing the big knock-knock on your doctor's door and say, why can't I have rescue for days when I flush or wheeze or have diarrhea?
This is another reason to see a specialist too, because the indication that the company has to adhere by law is they can only recommend 10, 20, and up to 30 milligrams of LAR a month.
Now it's approved for 40.
Right. Okay. Oh, good. So
And they hope to have it approved this year for 60.
oh, terrific. So, but still, a lot of your doctors may think that 30 is the maximum, won't go up anymore. When in fact, that's not true. I mean, Dr. Waltering, will infuse through a pump.
I use routinely LAR 30 every 2 weeks if I can get it,
Exactly.
the insurance company or Medicare to do it, and the pump wherever I can because it's the Rolls Royce.
Right. So this is why seeing someone who specializes in they can think beyond just the normal indications and what's printed.
Okay, Dr. Letitia, is there a blood test or a urine test that relatives can take to determine if they're susceptible to NETs, i.e. the genetics of NETs? if you think you got a family, let me just put in a plug for the National Institutes of Health. Dr. Steve Wank, W-A-N-K, is looking for people to go into his clinical trial for familial carcinoid. So anyhow, simple blood or urine test?
No, there's no simple urine blood test. Obviously, we always worry if in general, carcinoid tends to be a sporadic disease, but certainly you can have siblings and it can certainly run in the family. My colleagues, the Swedes, have looked at some of these things. They've collected several families, and a lot of them have certain mutations on certain chromosomes. Chromosome 18 is the most prominent one. And so there are certain things, but there's no easy tests. Certainly if you think you have symptoms and you think there's, diarrhea and flushing, then, you go through a regular workup. I think a regular workup would be.
And again, all data would say get a chromogranin A. There are so many people on proton pump inhibitors in the world that I have stopped using chromogranin as a screening test and have switched to pancreastatin because it's screwed up by the use of proton pump inhibitors, which, as you know,
What PPIs are.
proton pump inhibitors, PPIs, the purple pills, they're antacids, they're Afex, Nexium, Prevacid, Protonix, all those things they'll elevate your chromogranin, they'll elevate your gastrin, but they won't change your pancreastatin.
Neil would tell us more about this.
Yeah, whoever gets this gets my A for the day question. This is for Dr. Lutetia. Is a gallium-68 scan useful for any other disease other than NETs? Other diseases have somatostatin receptors. Have you had nodes light up for some other kind of tumor?
So that's actually a very good question. And so,
A for the day for that question.
yeah, it's a terrific question.
There you go.
So
She belongs to me.
So in general, it's been most touted, let's say, for neuroendocrine tumors. But there's a wide variety of neuroendocrine tumors. So that certainly is a carcinoid, pancreatic, things like that. But there's also paragangliomas and other things like that, meningiomas. But the question that Dr. Walton is asking is, what other things express somatostatin receptor? Well, it turns out lymphocytes express somatostatin at a very high rate. So could it be a very useful test for, say, certain types of lymphoma? These are things that need to be tested. But I'm working hard just to get it.
Let's ask the question in maybe a different way. If you get a false positive with an Octria scan, let's say the following diseases: renal cell carcinoma, thyroid cancer, sarcoidosis, some breast cancers, tuberculosis, the granulomatous disease, Wegener's granulomatosis, etc. Will they also be positive on gallium-68 scans?
So that's a very good question, because that's one of the huge criticisms of gallium. So the problem is when you have lymphocytes, so these are your white blood cells, if you have any sort of active inflammation, it will appear, okay? So let's say you had really bad arthritis in your shoulder. It might look like that. So this is where you have to kind of put various scans together in order to get a complete picture. Sometimes you can, for example, get little lesions in your bone, which look like they're positive, when in fact they're actually arteriovascular malformations. That's why you have to stick an MRI in there.
Angiogenic bone vessels,
They do. The density of the receptors, though, tends to be much lower than on typical neuroendocrine tumors.
What about renal cell?
Well, I've never done a renal cell, so I'm not so sure.
Okay.
I've never done, but renal cell.
They show up on Octria scan.
They're very immunogenic too, so it certainly could be. I mean, anything.
What about thyroids? Do you see a lot of thyroids? So I probably every week I see somebody with a thyroid uptake on an Octria scan.
Yeah, and that's,
do you see the same on gallium?
So the things you see on gallium, just kind of as background, would be your pituitary. Okay, that's very, very strong. It's almost like a positive control. Your parotids, your thyroid, and they tend to be the signal tends to be much softer than your tumor. Sometimes some images in the head of the pancreas, and the place where it's completely blinded is your spleen, your bladder, and your kidney.
Okay. Let's see. The economics of octreotide shots. I don't know if you guys go back to the carcinoid cancer Foundation. I wrote an article about this about 2005, and it was interesting. It was prompted by my mother's use of LAR because she had a metastatic neuroendocrine tumor, and at that time she was paying $5,000 per shot for LAR. It's now $14,000, I believe, at our institution. Many of the other institutions, $12,000. That's what the hospital bills. They get charged about $3,000 AWP as their cost of that medication. The insurance company writes off the vast majority of the $10,000, $12,000, $14,000 down to say like $7,500 is about the average payment from major insurance companies to your hospital for that. Based on my mom's insurance company, I went to Aetna and I said, hey, we can brown bag this, send it to the house, and their specialty pharmacy sent it to my house and I administered it, and you can get there's a program from Novartis where they will send a nurse to your house to administer it. And that brown bagging concept saves a lot of people a lot of money. The economy and the economics of medicine today is so screwed up. It's difficult at best. Okay. I think you addressed this, Dr. Thomas. Octreotide, and it was in your talk, octreotide doesn't just affect symptoms, it affects survival.
That's right.
That's critical, a take-home message. And the name of that study was PROMID, P-R-O-M-I-D, by Dr. Arnold in Germany. It is a study worth reading because if your doc says to you, the only reason I'm using this stuff is to keep you from pooping so much, you need a new doctor. Is it true about sugar causing cancer?
So that kind of
Is sugar a no-no for cancer? And what kind of diet do I need to avoid cancer?
Yeah, a diet question and alternative medicine question. The two favorite questions I get every day in the practice. From a nutritional standpoint, I always tell folks, listen, you got to try to maintain your caloric intake. Try to maintain your weight if at all possible, because when you're on these chemotherapy pills, the Sutent, everolimus, there might be some days where you're not able to keep up with your nutrition, your caloric intake. You may have a poor appetite. And so you're going to need some reserve to kind of get through those days by eating as much as you can and maintain your caloric intake. Now, for most people, I tell them, listen, there's nothing, you can have an acid-based diet, you can do an all-nutrition, apple diet or a carrot diet. Really, the cancer is going to do what it does anyway. It's going to act independent of your body, and anything you deprive yourself from your body from a nutritional standpoint is just depriving the rest of your body, the muscle, and that's why you can see some folks are getting cachectic or losing weight. Now, for folks who have carcinoid syndrome, if you're symptomatic, we would suggest maybe high-protein diet, low-fat diet, and maybe some niacin replacement. And those are sort of the routine.
And remember that sandostatin, if you use sandostatin, it tells your pancreas not to make pancreatic replacement enzymes that break down fat. So if you eat a piece of prime rib or a Colonel Sanders Kentucky Fried Rat, trust me, you're going to poop the next day because you're going to malabsorb fat, and that is going to turn out to be worsen your diarrhea.
You don't need sandostatin to have diarrhea after Kentucky Fried Chicken, my friend.
That's true. That is true.
And
Having lived in Nashville for 7 years, I know just where to go get my grease fix.
Now, to answer that question on the sugar question, I've noticed in folks who have the other kind of more aggressive cancer, the pancreatic adenocarcinoma, this tends to kill folks fairly quickly. But I got some folks who are about a year and a half with metastatic disease on chemotherapy doing relatively well, and I notice these guys have very, very strict sugar control. And there's some data that say maybe tight sugar control might be beneficial. So I'm not saying that you need to have a sugar of 80 to 100.
I would like you to read work done by 3 authors. Get your pens ready to go. Dr. Murray Brennan, Dr. Steve Lowry, Lowry, and Dr. Michael Burt, B-U-R-T. This is from the late 70s to early 80s when Dr. Brennan was at the National Cancer Institute, and then shortly after he went to Memorial Sloan Kettering. Dr. Burt had an unfortunate demise on a motorcycle accident about the same time, but Dr. Jeff Norton and Steve Lowry had worked with Murray, and what they did was they intentionally gave animals bearing tumors total parenteral nutrition at sub-therapeutic or sub-nutritional levels, and lots of sugar levels, and the tumors basically grew at the same rate. So again, there's a lot of interest in this, and this fad is like IV hydrogen peroxide. It goes around about every 10 years. Somebody will bring it up again, and then everybody will say, "Oh, don't eat sugar, you'll die." Nobody I know is getting out of here alive. Anyhow, Dr. Murray Brennan, Brennan, Dr. Stephen Lowry, Lowry, Dr. Michael Burt, Burt, and Dr. Jeff Norton, Norton, who's now out at Stanford.
But nutrition is very important, especially if you have a very complicated case. There are people who really are very good. Lillian, for example, who works with Dr. Weltering, is very, very experienced with dietary needs in carcinoid patients. So she's a great resource.
Somebody asked about black raspberry powder. How much do you use per day? Again, I don't recommend it unless you have diarrhea or unless you've been tested in my lab with your tumor. It costs about $10 a day, and the dose that I use is 1 gram per kilogram of body weight per day. Okay, back to Dr. Lutetium. What can cause Y90 not to work or do what it's intended to do?
Well, there are a lot of reasons. I mean, first of all, is if the uptake is not strong enough. The bigger problem is toxicity. So, if, for example, if you got the Y90 and it just destroyed your bone marrow, you wouldn't be able to get more doses. So, and sometimes there are patients in which their receptors don't recycle or they don't take it up well. I mean, there are many reasons. So I can't tell you exactly what the reasons are. I think it's mostly biologic.
Okay, a real quick question. Radiation dose that you get with a gallium scan, Artria scan, or CT scan, which one is the bad guy?
The highest is the octreotide scan. The reason is because the isotope we use is called indium-111, and it has a much longer half-life. So it's kind of like the lutetium. You want that long half-life in order to do it. The indium hangs around for a couple of days as well, too, so that's not exactly
56-hour half-life.
So the good thing about gallium is that it only has a 1-hour half-life, so essentially it burns away. So most of you who have come to my institution, I put you back on a plane the same day and no one's ever caused you a problem. And that's the nice thing about it. So the actual, even though we may inject more radioactivity initially, it burns away so fast in the sense that it gives off such a bright signal and just disappears, that your exposure is much lower. The exposure for a CT scan is moderate. It's low, but the problem is people get many more CT scans than they get gallium scans, and so that's a cumulative dose of radiation.
Okay, Phil, you had something to say?
So an interesting thing about the Artria scan is I've had a few patients, you probably had some too, that are syndromic with, say, carcinoid syndrome, and after they get the Artria scan, they feel better and flush less and have less diarrhea for a few days.
Which is interesting because the amount of octreotide in a Artria scan is 10 micrograms, not milligrams, like 30 milligrams you're getting in your butt, or 500 that you get as sub-Q rescue micrograms. It's 10, and for those people who get a symptomatic response, I'm not calling you a liar, I'm just saying I'm overly surprised because the amount of octreotide that you're getting is so low.
Unless they were sensitive to the indium.
Yeah, I guess you could, yeah. And remember, Artria scan, we treated 135 people with high-dose Artria scan as part of PRRT therapy before we gave it to Dr. Del Poisson to do. And those people, some people had dramatic responses to high-dose PRRT, 500 millicuries of indium compared to the 5 to 6 millicuries that you get as an Octria scan.
One thing to consider too, the biology of somatostatin analog is very complicated. And Dr. Odoriso talks about this a lot, which is there are some people who respond to very low doses of the octreotide, and there's some people who respond to very high doses, and they won't respond to the other way around. So it's more complicated.
Okay? The other thing is, remember, as you're traveling back and forth, coast to coast to see all the experts, probably the most radiation you're getting is from cosmic radiation being in a jet airplane. The guys who really have a significant radiation risk is the United pilot who flies from New York to Los Angeles and back every day, 5 or 3 days a week. That guy gets a boatload of environmental radiation. What is the difference in efficacy of PRRT versus radioembolization? Okay, this is a good question. So this is why you need an expert. You get somebody with 4 lesions in their liver. They can have surgery, they can have PRRT systemically, they can have embolization, either radioembolization, bland embolization, chemoembolization, surgery. The efficacy, let's just focus on this question first. The efficacy of PRRT, systemic PRRT versus radioembolization if you had 4 lesions in your liver.
Right, so I guess the question is, what are you trying to achieve, right? And then the other question is...
Live long and prosper.
And then the other question is,
Nanu.
He dates himself when he says that.
Yeah, I'm a dinosaur.
So just so everyone knows, so radioembolization is when the interventional radiologist shoots radioactivity just directly into your liver and sits inside there. Right. And the PRRT is what we're talking about too. This certainly has not been worked out well, okay, because there's no standard kind of when do you do these things and how do you order these things. But if you look at 4 solitary, not solitary, but 4 discrete lesions, as Dr. Welterman described, the PRRT probably isn't the best therapy for you because you have good lesions that can probably be resected, right?
Or even if they can, if they were around the portal vein, radioembolization takes the therapy to the problem. Let me just hop in here. My mantra that I chant is systemic disease, systemic therapy. Regional disease, regional therapy. Just like real estate. What are the 3 most important things about real estate? Location, location, location. What's the 3 most important things about regional therapy? Surgery, surgery, surgery. If you can take them out, they're gone. If you can't take them out, you still can do embolization, radioactive spheres, chemoembolization, and bland. Now, I want to ask you a question, and that is something we're seeing now that's scary. And that is, we've treated about 200 people with radioactive spheres. Those people, inevitably, I don't cure any of those people. I prolong their life. And at some point, they start coming back with systemic disease. Now I'm sending them for PRRT in Basel. They get lutetium. In the old days, they got yttrium, and now they're getting mostly lutetium. And I've now had 5 or 6 deaths from what I think is radiation-induced hepatitis. That I zapped them, number 1, in their liver with the spheres, and now I'm zapping them again with radiation intravenously on PRRT, and the people, I don't think in Europe, have caught on to the fact that they need to look at the dosimetry of the liver that they treated with the spheres before they give them the stuff over there. Have you seen those kind of people? They develop ascites, they develop liver failure, their clotting factors go down, their prealbumin go down, and they walk in and they look like somebody who's from Dachau. And they have this big fat tummy like I used to have, and they have ascites. You hit them over here, and it's like the Pacific Ocean.
Right, so what Dr. Walter is describing is a local toxicity. So just imagine, if you put a whole bunch of radioactivity into your liver, the problem is there's a lot of innocent bystander inside there, right? So that means that all that good liver is being hurt. And so that's why we always preach surgery, because surgery actually leaves all that, when you can very focally remove tumors, all the good liver is left behind, perfectly healthy. So that's why we do it when we can. But the problem is if you have this kind of spread pellet shot kind of disease, we can't cut all those things out. So now you say, well, what can I do? So then you pump radioactivity inside there. And then everyone gets some element of kind of a radioactive poisoning to their liver. But the liver is very resilient, and it usually is very forgiving. Now you have it in your bones, let's say, and then you hit the person with PRT. Well, guess what? Your liver still has that absorbed dose of radioactivity. So there is an element to it. That's why you have to choose very carefully and think about it. So, for example, when I trained in Sweden, we were careful to know how much radioactivity one could absorb. They do dosimetry, so they can personalize it to you. So those things are very, very important. There's no question. And one of the problems too, it depends on the quality of the work that's done as well too. And so you may have to adjust the dose. So for example, if you go see someone in Germany, they may adjust your dose based on your previous radiation experience. But it is all very important stuff, and that's why it takes a lot of brain power to, you're not coming to see us not necessarily just because of our personalities or our hands.
We may be nice guys and lucky dancers, but that's not what you're paying.
You're coming to see this, yeah. And,
there is a new little gizmo, this is hot off the presses, that is about the size of a LeSueur pea. And you can hook it on a tumor in your liver, and it transmits to a receiver system the dosimetry of how much you've given. So at the time of surgery, you could plant this in residual tumors. Then when you got spheres, it will tell you how much dose you got. And then when you got PRT, it will tell you how much dose you got and measure it from the inside. One of the problems with dosimetry is that it's all smoke and mirrors. They create a phantom, which is they take a casting of my beautiful body and they fill it with gel or bio gel. And they stick dosimeters down in the gel, and then they radiate from outside to see how much radiation is there. And that's not, we don't think the quality of radiation and the quantity of radiation, if you get it from the inside, like PRT or spheres, or you get it outside like you do for breast cancer, a rad isn't a rad. There are differences. Okay. Now one more question for Dr. Lewin, we'll give him a break. Gallium-68 SUV greater than 20. What's that relate to as a Krenning score? If I see a patient with an Octria scan and they have a Krenning 4, I tell them they're going to have a 75% chance of responding. If they have a Krenning 2, I tell them it's 25%. How does the Gallium-68 SUV compare to the Krenning score compared to survival and response?
So I can't tell you exactly, but there's in general, so the Krenning score, you have to understand, named after Dr. Eric Krenning, is a little bit of a gestalt, right? So it's kind of a measure between the intensity that you see on the Octria scan versus the liver and the other organs. And so ours is a little bit different. I can actually physically circle and tell you how much intensity image is coming out of your tumor specifically.
So that means you ought to also be able to tell me what the Krenning score is.
So, well, I mean, kind of. So you can compare, if you want to, you can compare the amount of SUV, so that's the number that we use, and it's a continuous scale, not just 1, 2, 3, and 4.
But it's over 20 that's the good one that you would send for therapy.
Right, exactly.
Okay.
And so that would compare to 4.
So
that would compare to a 4, for example. And so you can kind of do these things. And so in general, if you have an uptake less than 4, that's essentially going to be a 0. Okay, so and these are just relative, but it's like about 4 to 12, between 12 to 20 and greater than 20. So it's something like that. But you can also compare it to the background image of the liver.
Okay, Dr. Thomas, we're going to give Dr. Liu a break. We beat him to death now. And Phil will get another chance at this later on. Dr. Thomas, you've already answered why we treat carcinoids with LAR. Are there any other medications like LAR? How long can we stay on LAR? And as I understand it, Dr. Whoever wrote this, that chemo doesn't work for carcinoid. Is that true, or are my doctors lying to me? I added that in a little. Yeah, we had to throw that in there for a little punch.
So the other types of somatostatin analogs are lenalidomide. Lenalidomide is actually
Somatostatin depot.
a sister drug to octreotide. But in this country, it's not currently FDA approved for carcinoid, just for acromegaly, I believe. But some centers are using it if you're intolerant to octreotide, or maybe going on and using it already. I have not personally used lenalidomide.
I use it every day, all the time.
And so the other one is called pasireotide, and I think that's still in clinical trial, which has more of a pan-somatostatin receptor activity, and that might be another good option for folks. Now, chemotherapy, again, pancreatic neuroendocrine tumors tend to be a little more chemosensitive, but there are some carcinoid patients that can still respond to chemotherapy, so it's not a bad option to use in carcinoid patients, but maybe, hopefully, if we could identify some biomarkers, for example, MGMT, if they're deficient
There
in
was a
that.
paper that came out just recently, basically that said, if you have a carcinoid, the most likely 3 drugs are oxaliplatin, 5-FU, Xeloda, and carboplatin.
Right.
Those were the 3 drugs that you were most likely to respond if you were a mid-gut, well-differentiated lesion. And there will be genes, I'm sure, very, very shortly, that will be able to tell us that.
Right. Right now, at this point in time, we're treating everybody like they're the same, but genetically, they're different. And hopefully with some biomarkers, we can identify which patients will respond better with certain drug therapy.
Okay, 5 minutes left, so keep them short, guys. PRT trials are currently undergoing, they're started. We have our first patient identified, we're getting ready to treat them with lutetium.
So you guys understand what this trial is, okay? This is an industry-supported trial from a company in Europe. It is only for small bowel mid-gut carcinoid. It has to be metastatic, progressing, and it has to be non-operable. So there are very, very tight restrictions to it, and it's a 50-50 shot of you're getting it.
Right, it's a flip of the coin, you get octreotide at a higher dose, or you get the lutetium.
Right, Sandostatin 60.
What's the sad part about this trial? The people who participated in the trial, we jumped up and down their best Rumpelstiltskin act, and they didn't put a crossover design. We begged for crossover. So the people who failed lutetium would go on to high-dose octreotide. People who failed high-dose octreotide would go on to lutetium. They didn't do that. It's a one-time flip of the coin. You either get the lutetium or you don't, and if you don't get lutetium, you ain't gonna get lutetium, right?
Although you will get 60 of Sandostatin.
Yeah, but you ain't getting lutetium, which is why you're there.
But
You get
some would consider high dose of Sandostatin to be therapeutic.
Yeah, me. But you'd have gotten that anyhow. Okay, let's see. Lord have a duck. Do artificial sugars harm, anything you'd say about diet with artificial sugar?
I have no data on artificial sugars. I use them. I use them in my drinks, so I have no problem with using it.
Ask my ex-abdomen.
Cancer in rats, but somebody needs to tell the FDA cancer in rats is good.
Okay, after Xeloda, Timidor, Sutent, Afinitor, PRT, the tumors are still growing. What's next?
K-Fox, Sulfox, right?
Was that? Yeah, 5-FU, oxaliplatin. Yeah, you can use for 5-FU-based therapy.
Yeah, but platinum.
Yeah.
And then liver-directed therapy, perhaps, you control what happens in the liver, you control
Just
it.
remember, MIBG therapy, we haven't talked about it today. You get a simple scan, I-123 MIBG scan. If you don't have the somatostatin receptors, get an MIBG scan. If you're positive, we can treat you in New Orleans. I think we'll stop now, Mike. I got everything. I did an A for the day for the guys. We down to 4 questions. I'll use those. Leave them for Eric.